Will someone introduce me? Yeah.
Hello, good afternoon, Dr. Eric.
Hello, good afternoon.
It's our honor to be with us today, inshallah, during the Elekta Workshop, speaking about the brachytherapy updates.
Thank you. Thank you. It's my honor to be here as well. You want me to start?
Yeah, please.
Okay, thank you. Everyone, it's a quite strange situation to do a presentation without seeing the audience, but I hope you can see me and hear me very well and see my presentation. My name is Eric Seusing. I work for Elekta, the Netherlands. I'm sitting here at home in the Netherlands and talking to you. So that's a great technology we have that we can communicate on distance in this time of COVID-19. In the coming 45-50 minutes, I would like to present to you Elekta Brachytherapy solutions, share some knowledge on the clinical trends and the new developments we have done within Elekta to bring brachytherapy forward into the radiation therapy treatment of cancer patients. So let me continue. So if we look at the trends and the news, what's happening today in the world of brachytherapy, there are many publications and guidelines out there that really endorse the use of brachytherapy in the clinic. And the American Brachytherapy Society, ABS, even came with a statement last year: cure is possible if patients receive brachytherapy. And there are a lot of clinical evidence and publications out there that endorse this statement. There was a press release last year talking about HDR gynecological brachytherapy is critical in the success treatment of non-operable locally advanced cervical cancer. The addition of brachytherapy to external beam really increased treatment efficacy. It's directly linked to tumor control and improve the survival of our patients in certain stages of cervical cancer. There is also the endorsement by the Society of Gynecological Oncology, SGO, together with the Brachy Society, ABS, stating that conformal external beam therapies such as IMRT and SBRT should not be used as an alternative in patients undergoing primary curative intent for cervical cancer. Just clearly, brachytherapy is a must. If you have patients with cervix cancer to be treated, you need to have brachytherapy as a boost, complementary, in addition to external beam. Well, what are we doing within Elekta? We have developed over the years. As you know, Elekta purchased Nucleotron about 10 years ago. Nucleotron, the market leader in HDR brachytherapy. And part of the Elekta family for the last 10 years, we have been able to develop new applicators to support the treatment of cervix cancer using CT and using MRI technology. Today, if you look at what you see here is a typical anatomy and schematic spread of the tumor across the endometrium, parametrium into the vagina and the pelvic wall. Now, with this kind of shape of tumor or different shapes, you need more clever applicators to reach out with the radioactive source into the tumor. So what we have done, we have developed some years ago and introduced a few years ago our latest applicator, Phoenicia. Phoenicia is the first applicator in this world that is a click and go system where you actually don't need any screws or any bolts or whatsoever to connect the applicator. It's very easy to assemble, very easy to bring it into the patient, and it's very comfortable for the patient and can be used with our Flexitron and also with our microselectron system. This applicator can be combined for intracavitary. It can be combined in combination with interstitial as well. If you look at the dosimetric aspect, it's also the first applicator in the industry, in the radiotherapy market, that provides, next to parallel needles, also oblique needles. So a combination of parallel and oblique needles allows you basically to spread the dose up to the pelvic wall. And depending on the stage of the patient you treat, you can choose the different sizes, or you can also use only parallel needles depending on what you want to treat and how big is the tumor. So this is a quite nice applicator, quite nice. It's an excellent applicator that suits several staging of cervical cancer treatment. The applicator can be combined with several options. You can also, for very advanced stage where you have to go through the perineum, you can use a template. We have built-in templates perineal templates that can be used using the concept of prostate treatment. The same concept is used with the perineal template, to use sharp needles to go through the perineum to reach the region you would like to treat. There are also caps. We have cervical caps that can be attached to the system to treat tumors that grow into the vagina as well. It's a multi-purpose applicator. Depending on your needs, we can make different configurations for you. So you can use that to treat patients in a very effective way. The Phoenicia applicator comes in different sizes. We have the 22 millimeter, the 26, and the 30 millimeter diameter of the lunar shape ovoids. We have different lengths of intrauterine, and the intrauterine tubes, they are very small. They are 4 millimeter in diameter compared to the current applicators with 6 millimeter. This one is 4 millimeter, and the big advantage of the 4 millimeter is that you don't have to dilate the cervical channel too wide. It is very slim design that can easily be put into the vaginal channel. And as you see here, we have different shapes, sizes with different holes as well. So this, depending on the needs in the hospitals, of the clinics, and the kind of patients you have, you can either use the smaller size, mid-size, or large size. Also, a combination of the different sizes can be used in one applicator. This is an overview of the current applicators we have. We have the Utrecht, the Fletcher's XS stainless steel, and the Henschke applicator. This is a titanium. These are our current applicators, but we are continuing in developing and innovating applicators. And in the end, what we would like to achieve as a company is to create applicators that makes these kind of applicators redundant, come with new applicators. So a few years ago, we developed Phoenicia, and this year we launched a new applicator. We launched the applicator named Geneva. And Geneva is an applicator with a, compared to the ring, the Phoenicia, this is a tandem and ovoid applicator model to replace the current Fletcher models. This is an applicator designed for treating up to stage 2B and has the same concept of click and go as Phoenicia do have. It can be used for intracavitary as well, but also for interstitial, or a combination of intracavitary and interstitial. Now, if you look at the stages, this is data from Embrace in Europe from 2018, that in Europe, if you look at the number of patients coming for gynecological cancer treatments, about 75% is within stage 1 and stage 2. And within this group of staging, we have developed this applicator to be very effective in treatment. This is how the applicator looks like. And I want to show you a video in the next 4 minutes. I hope you could see it. and hear it as well. So that's the new Geneva Applicator we launched this year into the market, and it's a product we have CE mark and FDA clearance. We're selling it in Europe and the United States and other parts of the world. In some parts of the world, we are working on registration. So pending registration, it's available in several countries, and I expect we will have it in Egypt soon available as well. The other applicator, the Phoenicia, is already available. So with these two applicators, we bring a lot of innovation in the market to treat gynecological patients using CT and using MRI. But it can also be used with X-ray and cone beam CT as well. Once more, this is how it looks like, giving you an idea of the different elements. I think a quite interesting element is the multi-spreading clip and also the unique interstitial tube. Yes?
Yeah, it's possible to interrupt you just to ask one question to clarify this new applicator, because as we saw in the film, this is a very complicated applicators. Yes, it will get the new and good isodose distribution, but about the application, you know that we make all this in the small field.
Yeah, it can
Yeah,
also be used, it looks
yeah,
complicated because it has a wide variety of elements, but you don't need it all. There are some elements you might need. And in the discussion with you, we can talk about, okay, what kind of patients do you treat? What kind of
yes.
sizes do you like? Then we can make a combination of these kind of this of applicator for you. And it's, as you see in here, there are no screws. It's very easy to click.
No,
This is a
the part that it will be inside the patient, that's the two clips about, and then the needle. It's very complicated to do this in the very small field.
yeah,
As
yeah,
we
yeah.
know that
That is
the most popular one is the Ring 1 or Vienna 1 or Vienna 2 applicators. It's very easily applicator. But what about this? Actually, it's used now or just
well. We sold it to several customers in Europe. We have it in South America and Australia, and there are customers, as you know, in brachytherapy. You have doctors that like to use the ring shape, so the Phoenicia shape, and you have doctors that like to use the Fletcher model with tandem and overweight. So this one can be used as a tandem overweight surrogate for those patients. But it can also, even though you have needles in it, you can also use it simply for intracathetery. You don't need to use the needles depending on the stage of the patient you want to treat. So the intracathetery model can be used in here, and not everything is needed. The rectal retractor, some customers, some doctors use the rectal retractor, or they do a good tamponage and they don't need the rectal retractor. It's up to the expertise of the doctors. It looks complex because I show the complete picture, but in principle, it's very simple and easy to handle and to place in the patient. Also, for very small anatomy, you have very small ovoids. This is the smallest ovoid you can find, a 13 millimeter, which is very comfortable for patients as well. But if you are used to ring models, Phoenicia is the one you can use as well.
yes, okay, thank you.
Any more questions? Then I continue. So Geneva is our new, the latest innovation, and we will continue innovating our applicators to make it easier and practical for our doctors to use, and also most important that it is comfortable for the patient. Now, this is an element of Geneva I want to share with you, and this is quite unique. You will not find this anywhere in the market. This is what we call an I-tube, intrauterine tube. If you have patients which underwent a hysterectomy, so you don't have the cervix any there, and you want to treat the tissue scar because there is a chance of recurrence, you can use a needle. So there's no intrauterine tandem, there's no tandem, but it's a block needle. So you can place a needle in and punch the needle into the tissue to the distance you would like to treat the patient. This is quite unique. It's very new. It's a new concept. We have discussed this concept with a group of KOLs, a consortium group in Europe, North America, and Australia. And it's been tested and they like the idea. And actually, as I think last week, the first patient was treated with this concept of intrauterine tube, the IU tube, in Australia. And there are some publications on social media on that. So we expect in the future, we have high hopes of using this new feature into this Geneva applicator for specific patients that underwent a hysterectomy and might have a recurrence that can be treated with brachytherapy efficiently. So there's a wide range of applicators we have. We have the multi-channel cylinder, we have Geneva, we have single channel cylinders, and Phoenicia we have here, and Geneva, the latest applicator. So it depends on the needs in your hospital, the kind of patients, whether you choose for Phoenicia or whether you choose for Geneva. And this is something we discuss with you as our customers and go through your workflow, understand your workflow, understand the issues you have, look at your preference, and then we advise which applicators you can use. And of course, you can have a combination of both or only one of them together in combination with the multi-channel or the single channel cylinder. Now, that's about the gynecological side. If you look into brachytherapy, what else can you do with brachy? And we're working with several customers in Europe and North America to expand the clinical capabilities of HDR brachytherapy into new body sites, such as liver metastasis and primary liver cancer. The next video, about 4 or 5 minutes, will talk about treating liver cancer, whether it's a metastasis or a primary liver cancer, with HDR brachytherapy. And this is from LMU in Munich, where Dr. Stefani Corandini and team, they are treating liver cancer very successfully with brachytherapy. And just recently in the summer, they published a paper where they treated 1,000 lesions with this technology. It's a technology, brachytherapy, that you need to work together with the interventional radiology, and both with interventional radiology and brachytherapy, you can come to this optimal solution. This is a technique that's being used in a few clinics in Germany, in Scandinavia as well. And I want to share this insight with you so you can understand and see here what's going on beyond the traditional gynecological, prostate, and breast cancer. So the next video will give you some insight.
Today, we're at the hospital of the Ludwig Maximilians University in Munich, Germany, to see brachytherapy treatment of liver metastases.
Patient we treat today is a 78-year-old woman with a colorectal carcinoma. She has metastasis in her liver. So the first diagnosis was in 2018. There she had surgery, then she had adjuvant chemotherapy, and in May she had the diagnosis of liver metastasis. After that she had a resection of one liver met, and on follow-up now we found 4 more liver lesions. And here we can see the first metastasis, which is very close to the heart. And then we have another one here, and a larger lesion very central, close to the large vessels here. And then there's a 4th lesion here. And so we're going to treat all these 4 lesions today with brachytherapy.
The procedure starts in the interventional radiology suite. The patient is positioned supine, arm raised, being monitored by ECG and oxygen meter. Intravenous fentanyl and midazolam are given for sedation and analgesia. The placement of the brachytherapy catheters will be performed under fluoroscopy CT guidance.
We puncture the lesion with a needle where we can take out that soul inside of it, and you can put a steel guide wire into the needle, in the position where the needle is, take the needle out, and then you only have the guide wire in that exact position where the needle has been in the tumor. Take the needle off the guide wire and exchange that needle over the guide wire against a soft sheath. We use 6 French long sheaths that have a hydrophilic coating very important. If it is not coated, it will hurt the liver capsule. And the last step would be you insert the brachytherapy catheter, and then you have everything in place.
After the intervention, the patient has the brachycatheters inside already, and we have already done a planning CT in the Department of Radiology. We see now the brachycatheters on the planning CT. Here you can see how the catheters look on the CT. For example, in this larger lesion, we have 2 catheters. Then we contour the target volumes, the tumor, and the organs at risk. And following that, the physicists do the treatment planning and dose optimization. And here's the final dose distribution of the different lesions. And what is really important if you do liver brachytherapy is that you always have to treat the entire puncture tract of brachycatheter, because it prevents that you get some metastasis in the tract during follow-up.
The brachytherapy treatment can now start, and it will take 34 minutes. After the brachytherapy treatment procedure, a gel foam will be used to fill the puncture tract during sheath removal. First, a piece of gel foam will be cut into thin slices and then rolled up. Then gel foam tubes will be placed into sheets. When the sheets are removed, the puncture tract is closed with gel foam. Bleeding complications have become rare since this method has been introduced.
This patient today, we had 5 catheters and treated 4 lesions. In the bigger lesion, in the very central position, we had 2 catheters, and in the others we have 1 catheter per lesion. And we treated it with 25 grays. The benefit of brachytherapy for the patient is that it is possible to treat the lesion in a very short time.
So that is the presentation on brachytherapy liver. It's a quite exciting technique, but it's also very important to understand that to implement HDR brachytherapy in the clinic for liver, one need to work very close with the interventional radiology department.
Dr. Eric?
Yes?
May I interrupt the presentation? I would like to ask you about brachytherapy of liver tumors. What is the advantage of brachytherapy of liver tumors other than other ablative thermal methods? They are available and they are cheap. So we must have an additional advantage that makes us go to brachytherapy.
That's correct, as you say, Professor. It is brachytherapy. The advantage of brachytherapy is that you can deliver a very high dose within less than half an hour. But it can only be done if you have a good collaboration and good working connection with the interventional radiotherapy department. Now, what we see is that in some countries in Europe, like in Finland, Germany, and Sweden, there are such a high demand for treatments, and because of the scale of metastasis in the liver, that brachytherapy can be as an addition next to SBRT or other techniques. I don't want to say here that brachytherapy is better. It's just an addition, and it can only be implemented if you do have fulfill in the infrastructure of your hospital on that. So in some cases, it can, from the dose symmetric part, you can really deliver with brachytherapy very extreme conformal dose, which is giving a very good patient patient outcome. It's not a technique that I would say that would take over other techniques, but it's complementary. I hope you understand what I say.
Thank you, Dr. Eric.
You're welcome. Any other questions?
Any other questions?
Yes, Professor Saad Zaghloul.
Yeah, thank you very much for this video. Actually, CyberKnife can do the same without invasion, because only either you put a fiducial so to know it, or you can track it by other means. So again, what's the advantage of this method over the CyberKnife?
Well, I agree with what you say, Professor. CyberKnife can do it. You can do it with a very good linear accelerator as well. There are other techniques. But if you have a brachytherapy department and you have invested in brachytherapy, if you look at the economical aspect of it, brachytherapy is a relatively cheaper, cost-effective, economical treatment modality. So if you already have brachytherapy and you have a very good staff in the clinic and you can do it, why would you invest $1 million in CyberKnife if you don't have a CyberKnife? So it's just a matter of economics as well and resources. And it's what I said, it's a complementary for hospitals that already have brachytherapy equipment in place and they want to perform this treatment. It is possible. What I want to show you here is that at brachytherapy, you can do as good as well as a CyberKnife. If you don't have a CyberKnife, you can do it with your brachy. That's just a matter of choices in a clinic.
And so this is data about HCC, treatment of HCC by brachytherapy?
Sorry, can you repeat the sentence?
Do you have any data about treatment of HCC by brachytherapy, not a metastatic lesion?
Yes, there are publications on that. I think on our Brachy Academy site, you can find publications on it. Also, the Munich University Hospital in Munich, they published a lot of it. Professor Ricker, he is one of the leading interventionalists on this technique, and he did a lot of publications. Before joining Munich, he worked more than 10 years ago also in Magdeburg, where he introduced this technique. So there are publications, and if you cannot find it, we can share that as well with you if needed. We can get through contacts or contact in Cairo, and we can share that with you if you want. Okay, then I would like to continue also looking at the time. Just other body sites like breast, we also have Apbi, accelerated partial breast irradiation. As you know, breast is the most common cancer amongst women across the world. And in 2018, there were more than 2 million new breast cancer cases registered. And yearly, more than 600,000 women die of breast cancer. So breast cancer is really something that where brachytherapy can play a role as well. And also, there are many publications on HDR breast brachytherapy. Now, in this particular talk, I want to focus purely on the Apbi side, the accelerated partial breast irradiation, and looking at the staging. If you look at the staging, the early stage 0, 1, and 2, you have the surgical options, mastectomy or lumpectomy. In the lumpectomy section, you have radiation options, either no radiation, Apbi with brachytherapy, or whole breast irradiation with boost. And then you have the different options. I will not go into different options, but focus on this part, APBI with brachytherapy. Now, there are many studies, randomized and non-randomized study published over the last years, 5 to 10 years. And basically what they all say with brachytherapy, you have excellent to good to excellent cosmesis, and the local recurrence is within acceptable limits. I will not go into the details of here, but there are many publications showing that brachytherapy plays a significant role in patient outcome, and at the same time provide excellent, good to excellent cosmetic. Now, there was also a publication in the Lancet 5 years ago of the phase 3 Jack-Astro trial, where APBI is used with multi-catheter, and it was compared versus whole breast irradiation with a boost. The conclusion of this story is that the APBI brachytherapy leads to an equivalent local control rate and survival with favorable toxicity compared to traditional whole breast irradiation. Now, it was a publication 5 years ago. It was a level 1 evidence showing APBI with multi-catheter. It is as effective and very effectively reducing radiation exposure to the breast, to the skin, to the lungs, to the heart. We know on the left breast that you are very close to the heart, and you do whole breast irradiation, you have a dose to the heart, which can lead to late side effects. With brachytherapy, you can reduce that significantly. And there are guidelines showing that, giving support on how could you implement this kind of technique in the clinic. And brachytherapy can give a shorter treatment compared to whole breast irradiation as well. Some KOLs like Dr. Sternat, Professor Sternat from Erlangen, and Dr. Robert Kuski, they are the one leading this kind of APBI, and with them together, with these gentlemen, we work providing education and support our customers worldwide to implement this technique as well in their clinic. There was last year also a study published, the TRIUMPH-T study. It's a 3-fraction radiation technique to utilize to minimize patient hospital trips. So basically, the idea was to come up with a study, 3 fractions in 2 days. And that was this study all about. Now, just some summary of the study, the background. It was carried out between 2015 and 2017, 2 years, and 200 patients were enrolled in the study. For brachytherapy, a multi-catheter were used, or also the balloon applicators were used. 3 fractions, 7.5 gray per fraction in 2 days. And the objective was to check whether the toxicity was less or not higher than compared to the normal schemes. And secondary was to look also at the 2 years local control, and also determine what the cosmetic effect was after 3 years. There were some methods show the patient inclusion criteria, and also looking at the DVH criteria as well. Now, the conclusion was that after 12 months, all patients at risk for toxicity was follows, at least for 10 months. The conclusion was that 97% had an excellent to good cosmesis, and there was only 1 recurrence and 1 regional recurrence as well. So the outcome of this study in a median follow-up was that it looks promising, but we need longer follow-up to see how the outcome will be. And this was done last 2 years, and I expect in 2020 or 2021 that the TRIUMPH-T study follow-up will be giving a better picture how this, whether 3 fractions in 2 days is eligible or not. Now, for brachytherapy, you have several models, several modalities. You can do interstitial, you can use intracavitary balloons, you can use the intracavitary strut, and there are also IORT techniques as well. Within Elekta, we offer for APBI the OncoSmart catheters, so flexible catheters, and the modeling in treatment planning is quite easy to implement. The OncoSmart catheter we have is a 6 French tube with a 4 French needle, which is easy to implement in the clinic. This is going quickly through the verification, the workflow. So once you define the target, what you see here is a sample of rigid stainless steel needles can be used for catheter insertion, but we also have the flexible needles are very easy to implement and very comfortable for patient because it takes the shape of the patient anatomy as well compared to the stainless steel needles. This shows you how you click the system, and this is an overview of target delineation, till insertion, treatment planning, and treatment delivery. With the treatment planning, it's very important that you can visualize either with CT or primarily with CT, you can visualize the target, you can delineate the target, you can delineate the critical organ. Also, you can delineate the thoracic wall with the lungs, and if it's on the left side, also delineate the heart as well to verify the dose. There are contouring tools available where you can avoid the critical organs and also optimize, use inverse optimization tool to optimize the dwell positions and thus conforming the dose to the target and minimize the dose to the thoracic wall. There are also tools that allows you to do a very fast catheter reconstruction. In on-central brachy, we have a tool called Autocatheter Recognition, where you click on the beginning point of the catheter. Take, for instance, you see here the beginning points, all is green, and the system calculates throughout the catheter in a few seconds. It reconstructs the applicator for you very easily. This is a sample of a strut-based implant using the Savvy applicator, where you can do a very automatic implant reconstruction. Also, the reconstruction takes a few seconds, up to 30 seconds, to calculate the size and the position of the applicator. Now, with this kind of technology, we bring technology in the market, but we also do a lot in education. Elekta is very committed to educate our users, our customers around the world, and therefore we have developed a platform called Brachy Academy. The Brachy Academy is a peer-to-peer medical information and educational platform we have developed to support our professionals in the market. We organize workshops, we organize all kind of training, go-live support. Today with the COVID-19, we developed remote go-live support as well, where we have doctors or application specialists remotely guide our doctors in the field to use brachytherapy the first time in an educational through a Phantom or whatsoever. So with Brachytherapy Academy, the Brachy Academy, we support worldwide our customers to implement this technique, any technique for brachytherapy in a safely manner. So just briefly to close my presentation, the Elekta portfolio consists of several elements. We have a wide range of applicators, the Flexitron, treatment planning, and also for prostate, which I did not cover in this presentation. We have a real-time solution as well for prostate using ultrasound or in combination with CT and in MR. This is the real-time prostate solution. It's a quite innovative solution where you could use in a single environment under ultrasound guidance to implement applications, needles into the prostate, do a real-time dose calculation, optimize the dose, and treat the patient accordingly. With this technology, the patient does not move. You have the patient on the table. The patient is under guidance of ultrasound to place the needles, optimize the needles, do the plan and treatment, and the patient is out. It's a very nice technique, very effective in one location to use. So with that, I would like to thank you. I think we have some time for Q&A, questions and answers.
Thank you, Dr. Eric, for your nice presentation. Now floor is open to questions. Yes. Can I ask you the first two questions? Yes, about the applicator for Phoenicia Applicator.
Yes.
Yes, you said that you have either oblique needle or the barrel needle. How inside this applicator, when needle put, it will go oblique, or I should to make the needle angles before I put in applicator?
Yes, that is the advantage of our applicators. Normal, when you place the applicator into the patient, you stick the needles in. So you have a very narrow field of view to place the needles. Now, with our applicators, we use the ProGuide needle concept. You know which ring size you use. And then you decide, okay, I want to use parallel needles. You place the ProGuides in the applicator. And then you bring the applicator into the patient. And once you have the applicator in the patient, through the ProGuide, you push the needle either parallel or oblique. So the guidance before you go into the patient, you have preparations already, and makes it very, very comfortable and easy to implement the needle. How do you want it? Usually you do also in the mind when you have a patient, you know, okay, this is my target. I will need parallel, or I will parallel or oblique needles. Is it left or right? How many would I use? What I know in experience is that a lot of users, they don't know how many needle they will use.
Yes, exactly.
So they place the ProGuides. Let's say they place 6 ProGuides. And while they implement, they decide, okay, only 3 I can use. So you push 3 needle and the other ProGuide you take out. That's very easy to implement.
Yes. And the type of needles, this is a plastic or titanium one?
We use stainless steel needles, not titanium.
Stainless steel needle. And this
Plastic
MRI
is a
also
plastic.
compatible?
So we use a plastic tube. And we use an obturator, a stainless steel obturator, to guide it through the tissue. We take the stainless steel needle out and leave the plastic in. So it's a plastic needle. Plastic tube is being used to treat the patient. So it's disposable. We don't have titanium needle for that.
Any question more? Okay.
Thank you.
No, one question.
One question, okay.
It's rather a comment, it's a comment rather than a question. The cosmesis after the needle for the partial breast irradiation is less than other modalities because of the inlet, the site of the penetration of the skin will be more and more fibrosis in this. And so after many years, you get the lady with dimples representing the site of the introduction of the needle. While I guess the other types are not having this criteria. Again, we can do the partial breast irradiation with the VMAT or the IMRT, and it will give the same results, I guess. And it's finished within 1 week. So it's 10 fraction within a week, 5 fraction, twice a daily for 5 days. So that's also another option for the patient who has choose to have a partial breast irradiation.
That's correct. That's correct. It depends also, you know, brachytherapy is complementary. You will make the right patient selection to treat with brachytherapy. And certainly the comment you mentioned, doctor, about on the cosmetic on the skin, that depends on, there is a rule in brachytherapy that when you treat with brachytherapy, you make sure that the first dwell position is not very close to the skin. If it should be below 5 millimeters of the skin, then you don't get this effect of a cosmetic effect on the skin. And that's a rule in treatment planning which one should consider. And with HDR brachytherapy, you can do that very well. But of course, you are right, there are many options. And depending on the patient, depending on the tumor location, you can decide whether you do VMAT or you do brachy. And as I mentioned in the presentation, there is this TRIUMPH-T study where you can do brachytherapy in 3 fractions in 2 days, which is very, very short course of treatment. And of course, it's we're waiting for the 5-year results, but the 2-year results for a 3 fraction in 2 days looks very promising. So we are also very eager to see what the 5-year results will be for this 3 fraction for brachytherapy. But you're right, there are many options, and it's up to the clinic what resources, what expertise you have, what equipment you have, what you will use, definitely.
But I think if we are in center and they have both VMAT and the brachytherapy, actually, I think it depending on the side of the tumor and the patient preference. If I have more deep-seated tumor, the treatment with VMAT, it will lead to toxicity, for example, of heart or chest wall. While the treatment with brachytherapy, I saw actually the treatment with brachytherapy in the breast. Because the patient's fixed and the needle inside the tumor bed, you can give the very high dose and at the same time sparing the heart and the underlying lung. And I think
absolutely.
Yes, and I think the cosmesis we spare at least 8 millimeters from the skin. So the whole area, the cosmetic results, I think in some of the papers that is published comparing the external beam with VMAT in accelerated partial breast irradiation, the cosmetic results, it become better with brachytherapy because it has a skin sparing effect that's actually missed in the VMAT and IMRT. So it's dependent on availability. First one, number 2, the size of the tumor.
Correct, correct. Yeah.
To leave the 5 to... So
if superficial tumor near to the skin, I think it's better to go to IMRT and the VMAT. Yes. Thank you, Dr. Eric, very much.
You're welcome.
Nice and a collaborative presentation. And hope to see, inshallah, after COVID, less soon in Egypt.
Yeah, thank you. It was an honor for me to present at this distance, far away. And in this time, we do it this way. And I hope one day I can be physically available. We can have a conversation and meet each other as well. I wish you all a nice Congress and a good time over there in Alexandria. Thank you. Take care and have a nice day, inshallah.
Bye.